Bismillahirrahmanirrahim. My name is Dr. Kamran Shaikh, and I'm a liaison consultant psychiatrist working in the UK. So today's topic we are covering is delirium. So what is delirium, and how to assess it, and then how to review it, and how to diagnose it, how to treat it. So that's what we are going to look today. So and I'm going to the slideshow now. So uh, delirium means it comes from the etymology of the word. It comes from D and lira. So D means that like going away from something or absence of something, and then lira means ridge between the furrows. So that means that something is wrong in person's emotions and behavior, and that's how it's called like delirium. So the term was introduced in mid 16th century. Uh, so the next slide I'm trying to produce now. Yeah, so prevalence. So whenever anything you are seeing, you have to go by the incidence, prevalence of that condition. So that's how in the exams, whether you are explaining in anything in the cask stations, or if you are writing a book or an article, or or explaining to a relative, or explaining to the consultant. So explaining or writing a leaflet even for any website in any language. So you have to go through all these headers. So one thing we should be mindful in the exams: what is prevalence? So delirium is present in 10% of the hospitalized patients, and a further 10 to 30% of uh, 10 to 30% of patients develop delirium after admission. And then post-operative delirium occurs in 15 to 53% of patients, and it's 70 to 87% of those in intensive care. And that's why, so intensive care, so the more severe the illness is, more are the chances of getting delirious. So we get the most sick people in the ICUs, and that's why the ICU delirium prevalence rate is about I would say like 77% on average. So 70 to 87%. So if we take an average, it would be 75%, 77, 78%. So that's quite high. So let's go through the DSM-5 criteria. And let me say in the beginning, like for some illnesses, I like the DSM-5, but some illnesses I would go for ICD-10, and I think ICD-10 criteria are more in line with the rating scales, and they're more valid. So both are reliable, but the ICD-10 seems to be more valid on face value because it says many of the things, and we come to that in a moment. So DSM-5 criteria is a disturbance in attention, that is reduced ability to direct focus, sustain and shift attention and awareness. So reduced orientation to the environment. But my critique to that is the kind of it says awareness here, but not the conscious level. So it should say something about the conscious level as well. So, because awareness or reduced orientation, you can also see in dementia. So it's better that if they comment on conscious level, it would have been better. And ICD-10 is better in that respect. B, the disturbance develops over a short period of time. So it is quite acute. And that's very right. So usually hours to a few days, and it represents a change from baseline attention and awareness and tends to fluctuate in severity during the course of a day. So fluctuating course. And then in addition, there's a disturbance in cognition. So cognition, they include perception as well. So memory deficit, it will cover whole mental states basically. So memory deficit, language, visual spatial ability, or perception. And that's another, I would say that perception is such a great thing that should have been described like separately. It would be better. And then the disturbance in criteria A and C are not explained by another pre-existing established or evolving neurocognitive disorder. And here in the criterion D, they outrule dementia. But they could also do easily by like saying the conscious level, which ICD-10 says. Both are great classifications, but it's just a constructive kind of criticism. So, and do not occur in the context of a severely reduced level of arousal, such as coma. So when it is coma, it is, if it is severely, then it's more than delirium. Then you can't say it's delirium. It is beyond that. So it's very, very severe. And then there is an evidence from the history, physical examination, or lab findings that the disturbance is a direct physiological consequence of another medical condition, substance intoxication or withdrawal, or due to a drug of abuse or to a medication, or exposure to a toxin, or it is due to multiple etiologies. Now we come to the ICD-10 criteria, which makes more sense to me here. So the first thing, impairment of consciousness and attention with reduced ability to direct focus, sustain, or shift attention. So they are not using the term awareness, they're using the term consciousness. And that makes more sense to me, that there is a disturbance of consciousness and attention. And then B is, in ICD-10 criteria, that global disturbance of cognition or perceptual distortions. So here they are including the perceptual distortions in cognition, that's fine. So perceptual distortions, illusions, hallucinations, mostly in visual modality, impairment of abstract thinking and comprehension, and impairment of immediate recall and recent memory. So it's impairment of cognition, including the perception, and then disorientation for time and sometimes place and person as well. So here they are putting the disorientation in criterion B. And then the psychomotor disturbance, then that's another very important point, which is covered in ICD-10 but not in DSM-5, that psychomotor disturbance, the delirium can be hyperactive, normoactive, mixed, or hypoactive. So it could be hypoactive and hyperactive. It could fluctuate between hyperactive and hypoactive. And then another thing which is additionally covered in ICD-10, sleep-wake cycle. It is typically nocturnal worsening of symptoms, daytime drowsiness, sleep reversal, and then disturbing dreams and nightmares which may continue as hallucinations on awakening. So even people can get nightmares and they can become delusions in the morning, or they can continue as hallucinations on awakening because they are so vivid. And then finally, emotional disturbances. Again, depression, anxiety, fear, irritability, euphoria, apathy, or perplexity. So again, ICD-10 is touching the emotional bit as well. So mnemonic to remember, and I think the good thing in DSM-5 is it says acute onset, and ICD-10 is not very clear in its being an so. But when I combined the two and made a mnemonic, so it's in line with ICD-10 and to some extent DSM-5. Camp David. So C for conscious level altered, impairment of consciousness, clouding of consciousness. A for attention and concentration decrease, and M for memory and cognition disturbances.
Sir, is
And
there any way that can the slide share on?
are you having slides or not at the moment?
Not at the moment.
Oh, okay. Sorry. So let me revisit that. Share screen, switch. Can you, no?
I was able to see the slides.
Okay, then maybe it's just me.
Okay.
Me too. I was earlier. I could see you.
Okay. Can you see anything now?
For me, it is blank.
Okay. Okay. So let me stop share and share it again. And I think slideshow is a bit tricky. So can you see anything now?
Yeah, we can see your slide.
Yeah, so I think I will go with slide sorter rather than slideshow, because slideshow can be a bit tricky. Can you see the slides? If it is okay, I will continue with the slides.
It is visible now for me. Other people, I don't know.
That's fine. So yeah, okay. So okay, so the next bit, so we were on DSM-5 criteria. That's the slide for DSM-5 criteria, ICD-10 criteria, and then the combination of two and a mnemonic by me. So Camp David, so conscious level altered, attention and concentration is decreased, and impairment of consciousness and attention, memory and cognition disturbance. Can you see the slides, everyone?
Yeah. Yeah.
Yes, sir.
Okay. So P for perceptual distortions, illusions, hallucinations, and mostly in visual modality. So the visual hallucinations are so important in delirium that they can be auditory, visual, olfactory, tactile, but mostly it is visual. And then it is psychomotor disturbance between hypoactivity and hyperactivity, day-night reversal, So I put everything from ICD-10 into this mnemonic. So disturbance of sleep-wake cycle, nocturnal worsening, diurnal variation, and dreams and nightmares. And then A for acute onset or all of a sudden, whatever you can say. So disturbance is usually hours to days. And then increased emotionality. So and then like hyperactive depression, emotional disturbance, anxiety, fear, irritability, euphoria, apathy, perplexity. So you can see any emotions in delirium. If it is hypoactive delirium, it is likely to be depression and maybe some anxiety. If it is hyperactive delirium, the fear is likely to be heightened, irritability, euphoria, uh, and perplexity, they will all be there in hyperactive delirium. While apathy is one thing that uh, it will be in a kind of a hypoactive delirium. So disorientation for time and sometimes place and person as well. So disorientation, time, place, and person. Uh, Now I think my slides will be more clear to you. So disorientation, you see for time and place and person, and that's one of the differentiating things is clouding of consciousness and disorientation. Because if you are working in accident and emergency department anywhere and they ask you to see the patient is unlikely to be disorientated in functional psychiatric illnesses unless there is an advanced dementia of any kind, especially the Lewy body dementia, but any kind. The patient can be disorientated, but then you will not see the disturbance of conscious level. The second thing you see in the disorientation bit in functional, that very advanced schizophrenia people, they are not disorientated, but they are unlikely, they are not unable to tell you about the date and time and place and person because of their perplexity, because of their severity of schizophrenia. So that doesn't mean that they are disoriented, but they appear to be disoriented. But here, the person will be clearly disoriented and along with altered conscious level. So that is delirium. Risks. So again, mnemonic SAD. So starvation risk is there, self-harm, self-neglect can be there, aggression and agitation can be there, and absconsion, like escape from the hospital, deterioration of medical condition, and of course, coma and death. They are all the risks with the delirium. Okay, and so the next slide is, has anybody ever used confusion assessment method scale, CAM?
Yeah,
No,
during
sir.
training days we have used, but uh, later on most of all are clinical only.
Yeah, okay. Yeah, so it's a good practice, to use that, especially if you want to prove to the medics, because the medics, they will sometimes say, oh, the patient is schizophrenic, the patient is psychotic, take them to the psychiatric ward. So sometimes to prove to them, you might have to do the scale to illustrate that, yes, they are not psychotic, but they are delirious, or sometimes to make yourself sure that they are a psychotic, or sometimes if you are not very good at your knowledge base. For example, if you're asking a nurse or anybody or a very junior house officer who has just started psychiatry, so this scale will be, much more efficient for those people, for the beginners, and it will give you some measurement. So it will tell you acute onset as from DSM-5, inattention, disorganized thinking, and then from ICD-10 it will tell you altered levels of consciousness, will tell you about disorientation, memory impairment, perceptual disturbance, psychomotor agitation, psychomotor retardation, altered sleep-wake cycle. So it will tell you about a lot of things. And then there is another one. So that's the confusion assessment diagnostic algorithm. So whether it's the feature 1 is acute onset, feature 2 is inattention, then disorganized thinking, altered level of consciousness. So those will be like 4 features which will be covered here. And then after that, and then the rest will be the other features. So, but there is another variant of a brief scale of CAM, which is CAM ICU. Has anybody come across ever CAM ICU?
No.
Okay, CAM ICU, like it was an information to me as well, because I knew only CAM when I did my SPR in psychiatry. So, but then I came to know that yes, this is also one thing which exists, and that's a brief version of confusion assessment method, which is called a CAM ICU. So in ICUs, what happens is that so in ICUs, what happens is that the incidence or the prevalence of delirium is so common that what happens is that nearly everybody you have to screen for delirium, and it is meant for the nursing staff working in the ICU, in the or the doctors working in the ICU. So it is easier for them to do a brief scale, and they can do, it's more of measuring the severity. So they can do it every day if they like. So can you see my screen now?
Yes, sir.
Okay. So CAM ICU, it's relatively brief. So they will just check the 4 parameters. Like where for the first one is level of consciousness, and then the content of consciousness, fluctuating course of mental status. So that will be the worksheet. Acute or fluctuating course, there or not. Inattention, level of consciousness, or disorganized thinking. And then they will say CAM ICU criteria met, like a feature 1 plus 2 or 2 and 3, or 2 and 4 positive. So then we'll say that delirium is there. So the nursing staff in the ICU or the medical staff in the ICU, they can do it every day if they wish. So it's so much easier to do. And if we compare it with the CAM, so they are just the like the so let's go back to the CAM here. Can you see the slideshow now? Yeah. or not?
Slide is visible, sir.
Yeah, so you can see the confusion assessment method, yeah? So acute onset, disorganized thinking, level of consciousness, and and altered level, so these four things, they make the CAM ICU. And then there are other things you can just skip in the CAM ICU, but if it is complete CAM, you have to go through the full version. So you can see these slides now, and then the CAM ICU. So this is the CAM ICU. Like items are that acute onset or fluctuation of mental state, inattention, altered level of
Slide is
consciousness.
not visible now, sir.
Okay, so I'll switch window, and where is it? Yeah. Yeah, you can see now?
Yes, sir. Yes.
Okay, so this is CAM ICU. So whenever you go to assess the patient with delirium, it is good if you have time, do the CAM. And if you have and then for measuring everyday progress, just do CAM ICU on the like the further follow-up visits. And good thing in liaison psychiatry is that what we do in the UK and Ireland, we note down the name of the patient and put him in our list. And the medical ward do not have to call us again. We feel it is our responsibility to go and check the patient in the medical ward once again in 2 or 3 days or 1 week, whatever. But we feel that it is our responsibility and we go spontaneously. So that will be a good practice. They don't need to call you. If they call you, that's fine, go. But from now on, make that your practice in Pakistan, Arabia, or India, that the medics don't have to call you, and you know that yes, this patient will need a review, and I will see this patient in 3 or 4 days, or whenever my on-call shift is, my liaison shift is. Like when I was working in Pakistan, we had the liaison days. So such and such medical officer will cover the liaison work. So whenever your day is, just remember the previous day, and and if you have seen anybody, and the next day you hand it over to the next on-call medical officer or PG trainee, that yes, I saw such and such person in the renal ward or in medical unit 3, and he or she was having uremic encephalopathy. She was so agitated that I had to give her very low dose of olanzapine or haloperidol, and could you please see her today? Even if the medical people, colleagues don't call you, even then, if you can see, I'll be grateful. If the person needs daily reviews or alternate. So it's good to hand over the liaison work every day to your colleagues. Okay, so causes of delirium. There are multiple and various mnemonics all over the internet, and I was searching for the delirium one. Like I made positive and other so much mnemonics, but the easiest like the mnemonic to remember is delirium itself, because you can never forget. So if you just wrote, learn that mnemonic. So D for drugs and medications, D for degenerative, like degeneration or dementia. It is mainly a risk factor for delirium. It is not a direct cause, it is a risk factor, but Lewy body dementia can sometimes present with delirium from time to time. That is within the course of Lewy body dementia, fluctuating level of consciousness. So that's the only dementia where the fluctuating level of consciousness is a part of dementia symptoms. But all other dementias, the conscious level should not uh, deteriorate, but it can, and they all the dementias are at risk of getting delirium. But in Lewy body dementia, delirium can become a part of the symptoms of Lewy body, core symptoms of Lewy body dementia. Delirium is one of the core symptoms of Lewy body dementia from time to time, not always. So recurrent episodes of delirium. Then E for epilepsy or electrolyte imbalance, hyponatremia. For example, hypomagnesemia, hypocalcemia, anything. So that's E. L for liver failure, which is hepatic encephalopathy. L for low oxygen. So again, low oxygen, it could be low oxygen in the brain, or it could be low oxygen anywhere. And low oxygen, it could be myocardial infarction. So it will be covered as a low oxygen. Hypoxemia, and think of ischemia, infarct, pulmonary embolism, all kinds of hypoxic things. Because sometimes the silent myocardial infarction only presents with delirium, and sometimes even not that. But it, especially in the diabetics, there will be no other symptoms, silent MI, but a delirium. So it's so important to know that bit, that it can present with delirium only, silent MI. Similarly, pulmonary embolism, infection can be inside or outside the brain. So it could be a very common and very simple thing to check, which is urinary tract infection. If you have gone to the medical ward, they say we have done all the blood tests, we don't know why, and you know that the person is a high risk, may or may not be a high risk patient. For example, person may be learning disabled, or person may have mild dementia, or they may be autistic, so they don't know how to express themselves. They can straight go into delirium. And one of my patients in the Republic of Ireland, she always presented with recurrent episodes of delirium. And this was the only one time we actually used to treat her in the psychiatric unit, because we knew that the medics won't take, and we knew that it's always UTI. So rather than fighting and arguing with the medics, we sometimes treated her in the psychiatric unit, which is not ideal. Ideally, it should not happen. And when I was doing the liaison work in the general hospital, I knew the case, and then I was able to convince the medics that yes, please, treat her in the medical unit. She is having UTI. I know her from psychiatric units before, and they then obliged me and treated her with the UTI, for the UTI. And when her UTI was over, then there was underlying mental illness, which was bipolar, depression, or mania or hypomania. And then for that, I transferred her back to the psychiatric unit. So that can complicate. Sometimes there can be both. And that was one of the reasons we were treating her in psychiatric unit, because she was depressed or having mixed affective episode at the same time. So it's important that even if though there is a functional illness, look for delirium. And there can be a comorbid delirium even with the functional illnesses. Uremia or uremic encephalopathy. that can happen. So, and again, EGFR, estimated GFR is one thing you should look for, especially in the treatment in the patients with kidney failure. And urea creatinine will also give you some idea, but the EGFR will be more accurate. Metabolic and endocrine. So diabetes, hypoglycemia, diabetic ketoacidosis, thiamine, other vitamin deficiencies, Cushing syndrome, thyroid problems. So anything related to metabolic or endocrine system that will come under the causes of delirium. So go to the next slide. Yeah, so causes of delirium, again, this is from the book. So it could be degenerative, D for S for space occupying lesions. So we have covered is intracranial infiltration or space occupying lesion. So infiltrative lesions will be more of a malignant nature or metastatic nature. Non-infiltrative lesions can also be there as meningiomas and benign tumors. So, and they can also cause. So any cerebral tumor, subdural hematoma, cerebral abscesses, so any space occupying lesions, trauma. So we covered here in eye. Add here, yeah, it's intracranial injury. So injury to the head, or we can put as an additional injury here as well. And then the next, so infection, inflammation, vascular, we cover that as low oxygen here. So low oxygen, that will cover the vascular. And epilepsy, so E for epilepsy, M for metabolic and endocrine. Toxic, we covered that in D here, drugs and medications. And anoxic, again, hypoxia, bronchopneumonia. So the genuine hypoxia from respiratory system, we can say that it can cause. So hypoxia can be of vascular origin or from respiratory origin, or of a cardiac origin, cardiac dysrhythmia. A vitamin lack, that will be covered here in metabolic and endocrine in the mnemonic. So I'm just making sure that our mnemonic is complete and covers everything. So types of delirium now. Delirium could be hyperactive or hypoactive. So could be like a patient who is having increased motor activity with agitation, hallucinations, inappropriate behavior. They're disturbing the other patients in the bay or in the ward, and they're uh, just sometimes attacking other patients, sometimes accusing them of spying on them. कि ये मुझे जहर खिला रहा है, मैनू मार देना है, let's say in Punjabi, she will kill me, she is trying to poison me. So these things will occur in hyperactive delirium. And hypoactive delirium, the patient is perhaps going into a coma, unless they are very severely depressed and there is another cause for hypoactivity. But if there is no other cause, then they are actually, it's a pre-comatose stupor state, medical stupor, not psychiatric stupor. And that can be characterized by reduced motor activity and lethargy, and has a poor prognosis. And then mixed delirium. Mixed delirium is there are some features of hyperactive delirium and some of hypoactive. Reduced motor activity is there, but hallucinations are also there. Or the patient is so fluctuating that 1 hour, 2 hour, he is totally hypoactive, and then another 2 hours he becomes really hyperactive, and then another 2 hours he's lucid even. So they can be even lucid. They can talk, just they will make sense at some times, and you can talk about like if they are suffering from any terminal illness, you can ask about things, serious matters about their life, their decisions, and they will be able to make decisions during those lucid intervals. Risk factors, so not the causes itself, but the risk factors. So one of the risk factors, we said dementia, learning disability is a risk factor. And and then we covered one thing in the drugs and medication as the cause. But when you combine many medications, especially in the elderly population, they are at risk of getting delirium at the same time. So polypharmacy, but unfortunately there is no other option other than polypharmacy in some patients, because patient is having hypertension, you have to give them something for hypertension, but all you can do is you can request the medics to give one antihypertensive in higher doses rather than combining two in lower doses if possible, but otherwise you can't. So if they are antihypertensive, you have to give. If they are on statins, you have to give. If they are on aspirin, you have to give. If they are on anti-diabetic, you have to give. If they are having vitamin B12 deficiency, D3 deficiency, there's no other option, you have to give. If they are having rheumatoid or osteoarthritis at the same time, you will have to treat their pain. So unfortunately, in some patients with multiple problems, you have to treat them with polypharmacy. All we are saying is that it will increase the risk of delirium in the long term. Anticholinergic drug use. So more the anticholinergic side effects of any medication, more is the risk of delirium. That's why, as Professor Nasir Said said, do not use Camadrin or Campro or procyclidine in routine in schizophrenic patients, because that will increase the chances of their confusion, and that may lead to cognitive decline ultimately. So if you can use very low dose of haloperidol rather than using high dose haloperidol along with procyclidine, that is much better. Please mute yourself if somebody has unmuted. Thank you. Okay, so so previous history of delirium, again, it is a risk factor for the further history of delirium. So when you are assessing for delirium, you go to a medical ward, take all these parameters into consideration. So you should see all of their medications, illicit drugs, and problem list or the past medical history. So the problem list, like that, yes, they have hypertension. So whenever I go, I make a full problem of lists. So kind of hypertension, diabetes, ischemic heart disease, renal insufficiency, hepatic insufficiency, and then on psychiatric side, patient has a recurrent depressive disorder and maybe comorbid anxiety disorder or OCD. So make the full problem of list, and the bigger this list is, the more chances that they are at risk of delirium because of their illness and because of the polypharmacy, because of that. So multiple comorbidities, and then previous history of delirium. So ask the relatives, did they get confused ever in the past as well or not? Stroke, neurological diseases, they all increase the likelihood of delirium. And dementia, as we have already said. And then the prognosis of delirium is the patients with delirium have an increased length of hospital stay, increased mortality, increased risk of long-term institutional placement, and hospital mortality rates of patients with delirium range from 6 to 18%. So twice that of matched controls. And especially if the delirium is hyperactive, they are more likely to survive. And if they are hypoactive, they are more at risk of dying. So if they are having hyperactive delirium, tell the medics yes, that they can treat that delirium, the patient can get better, and they should try to find out as many causes as possible and treat the cause. So in older people, the 1 year mortality rate associated with cases of delirium is 35 to 40%. So again, if the people are older, it's 35 to 40%. So that means that even there, the delirium is treatable, especially if the hyperactive delirium. So try to treat that, and the psychotropics can be used as a last resort in treatment of delirium, but the main treatment is treat the cause, whatever it is. Treat the cause or treat the all possible causes. Up to 60% of individuals suffer persistent cognitive impairment following delirium, and these patients are also 3 times more likely to develop dementia. So that's one of the side effects of or long lasting effects. And I have seen people, more than one people, like going into mild cognitive impairment or even getting advanced dementia, which started off as a delirium. So try to prevent that. And one thing I must say, in my country, the good surgeons always do, but some of the surgeons may not do is like the giving the like the anticoagulants. So after every surgery, they should use anticoagulants. And if you go to see a patient as a psychiatrist, just see if they are giving anticoagulants or not, and discuss with them that if you have any guidelines, remind them that, if, because it could be something like pulmonary embolism which is causing delirium, or it could be something like mini strokes, multiple TIAs, multiple infarcts going into the brain. So patient came with a hip fracture or a femur fracture, and they treated, and they're excellent surgeons in Pakistan. The surgical skills are excellent, and most of them are good at pre-operative and post-operative care as well. But sometimes heparin or low molecular weight heparin is missed, so it shouldn't. It will be a protective factor against all these thrombotic phenomenon, because the thrombosis is increased. So post-surgical, it should be, in my opinion at least, that there should be anticoagulant cover. So the next thing, management. So preventing delirium is the most effective strategy of reducing it. And that's why I said use the anticoagulants before the patient dies of pulmonary embolism, or before they go into dementia from multiple infarcts going into brain. Delirium is a medical emergency, and the underlying cause should be treated. Non-pharmacological or environmental support strategies should be instituted wherever possible. So coordinated nursing care. So if the psychiatric nurses are seeing, they should liaise with the medical nursing. Or if you as psychiatrist are going there to see the patient, talk to the nurses as well. and tell them, educate them about delirium and how to deal with them. Preventing sensory deprivation. So the room should not be very damp or dark. Any sort of lighting should be okay. It should not be overlit, but normal one or two tube lights, or ideally one tube light, one bulb should be okay in the room, or daylight coming should be okay. But there should not be any sensory deprivation. So if the curtains, you can move the curtains and let them see outside. Let them see that it is the morning or evening or afternoon. So, and prevent disorientation, reorientate them, tell them that this is like aaj hafte da din hai, it is Saturday today. So you can reorientate them, maintaining competence. Then one-to-one RMN or HCA, that is a concept which is written in some books and not in all. But this is one thing, that if the patient is so high risk, uh, they can be like healthcare assistant or one-to-one registered medical nurse should be present with the patient at all times. If the relative of the patient is there, that's fine, and if they can manage. But if they can't manage, or if they have to go, and in UK and Ireland, relatives do not stay for all 24 hours, they come and go. So at that time, some patients with, especially with hyperactive delirium, may require a one-to-one registered medical nurse. Or if they are ICU patients with hypoactive delirium, and if they are dying, their vitals are not stable, they will require a special nurse anyway. Then it can be treated with the Mental Capacity Act, not the Mental Health Act usually, unless there are other reasons. So the patient lacks capacity, and let the medical doctors, the physicians, let them deal with that. So you should not detain them from a psychiatric point of view just because of delirium, although in some mental health acts it is a provision. Pharmacological treatment should be directed first at the underlying cause, if known. So anyone knows which is the pharmacological treatment which treats the underlying cause? Can anybody tell?
Sir, that depends upon what is behind that
Yeah, what
delirium. Like
cause?
उसी से,
What cause will be there which you
sir,
can treat with?
infections,
No, yeah, that's fine.
if there
So
are
infection, yeah. So so
constipation can
basically,
be treated.
exactly. So that's the pharmacological. And my next question is, what psychotropics are there which can treat the cause?
So there are first generation
Anti-
antipsychotics or and
Antipsychotic.
yeah.
Say that again, please.
Sir antipsychotics first generation and second generation से दोनों use करते हैं.
Yes, both can
Yes,
be given. Yes,
that's fine, but they will not treat
yes.
the cause. In my opinion, the treat if the cause is alcohol withdrawal, and then you can use the
Haloperidol.
benzodiazepines,
Chlordiazepox.
chlordiazepoxide,
Mm.
to
Antipsychotics are contraindicated in alcohol and Lewy body dementia, as per my
antipsychotics
information.
are not. I will come to that. So if you everyone mutes their mic, and I will answer that. Please, you mute your mics, please. Mic, please. Okay, so yeah, antipsychotics, first of all, given, they can be given in in any case other than like alcohol detoxification. Uh, in Lewy body dementias, they can be given, but very low dose, and the medication which is least likely to cause extrapyramidal side effects. So, for example, aripiprazole, extremely low dose, 2.5 to 5 milligrams of aripiprazole, or if it is a syrup, you can give 3 milligrams. So, or quetiapine. But and then it can treat the symptoms. So mainly the antipsychotics won't treat the cause unless there is a comorbid psychosis going on. It will treat the psychosis but not the cause. So they are mostly symptomatic, or they can treat the psychosis. And the cause is, it's always something medical. It's not psychiatric usually, apart from Lewy body dementia. So, and then at the relief of, so the pharmacological treatment should be directed first at the underlying cause and then at the relief of specific symptoms of delirium. So the pharmacological treatment for the cause will be, as you said, antibiotics, very important. Or if the patient is having MI and you're sure you have diagnosed, then maybe the CCU people, the cardiologist may give them morphine and whatever treatment for their MI they want. And similarly, and then for the specific symptoms of delirium, yes, you can use low dose antipsychotics. Common errors in the pharmacological delirium management of delirium is that antipsychotics are uh, number one, they can be used very early, or like or very high doses, or sometimes they're given too late, or to overuse benzodiazepines. So benzodiazepines should not be used if at all possible. So in extreme circumstances, you can use, if the patient is not getting controlled by olanzapine alone, then maybe you can, but try to avoid benzos apart from the alcohol or drug withdrawal delirium. Otherwise, try to use the antipsychotics. But I remember, like, one of the patients was having a hypoxic brain injury. Because how they got hypoxic brain injury, let's say they had a myocardial infarction, or they were ventilated, they were coming out of ventilator, and they stopped breathing for a couple of minutes, and they got hypoxia of brain, and that damaged their brain. So
Sir,
because
is there any chance that antipsychotic itself may aggravate the delirium? Any chance is there?
unlikely. I mean, everything can happen, especially with the anticholinergic effects. Everything can happen, but it is relatively unlikely. And of course, if you're giving excessive doses, they can, and that's why try the minimum dose if possible.
Sir, I have to ask a question. Apart
Yes.
from benzodiazepine, if we need to sedate the patient and we don't want to use benzodiazepine, what else can we use? Because over here, I don't think so. Olanzapine injections are available, and we have
Okay.
like IV drugs. So,
Okay. Then I would say that haloperidol injectable, and then the other thing you can combine with could be either promethazine if the pulse rate is not too high. So because promethazine has its anticholinergic effects, or sometimes lorazepam as a last resort. But try to give lorazepam, or even giving oral olanzapine if the injection is not available. If the patient can take orally, give them orally. If they are NG fed, or or rig fed or peg fed, they can you can use the olanzapine orally. If so, try to avoid injections if at all possible. But when you have to, and there is no other way, then try giving only haloperidol. And if the patient is still agitated, then maybe lowest dose of either promethazine or lowest dose of lorazepam can be combined.
all right, sir. Thank you.
Okay, so uh,
Excuse me, sir.
Yes.
Injection Phenergan can also be given. I think it contains antihistamine.
Yes.
Clo-
Yes.
uh, I
Yes.
guess
That is promethazine.
chlorpheniramine.
Yes.
It's chlorpheniramine or
Promethazine.
okay,
Promethazine.
okay. So it's come
So
in Pakistan as the brand name of Phenergan.
Yeah, Phenergan. Yeah, yeah.
yes.
So that's fine. Phenergan or promethazine can be given, as long as you're not worried about the too much anticholinergic side effects, and especially if the pulse rate is under control. If the pulse is less
Mm.
than 100, you can take the risk. If the pulse is already very high, it will cause anticholinergic effects and then may cause some cardiac side effects. Otherwise, yes,
Plus,
Phenergan can be given.
yes, antipsychotics they themselves are sedating, so they I don't think we
Exactly.
would need
Yeah,
to add on something.
yeah, olanzapine, especially, that's why olanzapine is the most preferred psychotic nowadays in delirium. Although mostly prescribing guidelines still says that haloperidol is the first line. Let's see what they say in May. In May, there is a new edition coming of mostly prescribing guidelines, and I'm eagerly waiting for that. And I will see what changes they have made to delirium. I think they may come to olanzapine as a first resort in delirium management. That's what most of the people are doing. Like Dr. Tayyib Ahmed Tahir, he gave a lecture about 6 months ago on delirium in the Pakistan Psychiatric Society, and he was speaking from the UK like me, and he also said that he uses olanzapine in his practice, and I also, when I worked under supervision of my other consultants, they mostly used olanzapine, and even now, that's my first choice. Although one of my patients getting haloperidol, but usually we try to use olanzapine if at all possible. And
So
olanzapine, the
other
edge is.
antipsychotics, atypical antipsychotics can also be used.
We'll come to that in the next slides. Yes, they can be. So, but olanzapine, the edge is that it has antihistaminic properties, and it is a potent D2 antagonist. So when you combine, it is a sedative as well as antipsychotic. With the haloperidol, it is a sedative, like it is an antipsychotic, but it's not as good as a sedative. So it doesn't have antihistaminic properties, and that's why you will have to combine some promethazine or some benzo in some cases. So keep the use of sedatives and antipsychotics to medications to a minimum. Use one drug at a time, and that is the edge of olanzapine. You don't have to use haloperidol plus lorazepam. If you can give oral olanzapine regular, if there is a delirium, and if there is a hyperactive delirium, with the hypoactive, why? Don't give anything to a hypoactive delirium. They're already, God forbid, dying. So why to give anything in a hypoactive delirium? Give something in the hyperactive delirium. Use one drug at a time. Tailor doses according to age, body size, degree of agitation. So of course, if there is a hypoactive delirium, they are already sedated. So unless they are trying to pull out their NG tube or pull out their tracheostomy, that means that they are having a mixed kind of delirium, hyperactive as well as hypoactive, and then you have to use the olanzapine in those cases. But otherwise, in purely hypoactive delirium, they are going into coma. Don't use any antipsychotics, don't use anything. Titrate doses to effect. Use small doses regularly and rather than large doses less frequently. So that's what the Maudsley prescribing guidelines are saying, is that rather than using PRN or SOS, give olanzapine regular. That's what we used to do. 2.5 milligrams Nocte or HS regular, 2.5 milligrams BD regular, 2.5 in the morning, 5 milligrams at night, according to the according to the need, and 5 milligrams BD, or sometimes 10 milligrams BD, or 20 milligrams at night, 5 milligrams in the morning, 15 at night. So you can go up to 20 milligrams. And of course, you will use the small doses, but at regular. And when the delirium is over, if the delirium is short lasting, then taper off olanzapine within a day or two. But if the delirium lasted so long, they are on olanzapine for several weeks, then they may continue olanzapine for another couple of weeks, and you just ask the medics to taper off the olanzapine in like in Asian countries, the medics who are treating, or you can call them to the psychiatric outpatients to taper off their olanzapine. So I think it will be better off if you bring them to the psych outpatients and then taper off their olanzapine. That will be much better rather than the medics doing that. So review at least every 24 hours. So I mean, in delirium, yes, sometimes you have to, some patients are at daily day reviews. So ideally it should be daily reviews, but of course it's very difficult. But if it is not, if it is possible, yes, review them as frequently as possible. And if you are taking turns as medical officers, then hand it over to the next medical officer that go and see such and such person. I started him on olanzapine, and just see if they are doing well, and if the medics are treating the real cause of delirium or not. Increased scheduled doses if regular as needed doses are required after the initial. So try to avoid the as needed doses. Usually we go for regular straight away. That's the most recent trend. And and then maintain an effective dose and discontinue 7 to 10 days after resolve. So that's the ideal tapering down time. And sometimes what happens is that the medics discharge those patients. So you can advise the medics that they should advise the patient to reduce and stop the olanzapine, the regular olanzapine you started within 2 weeks by tapering off. So if they were on 15 milligrams, at the time of discharge, make it 10, after 1 week, make it 5, and then after another week, stop. So, or you can call them to the outpatients, or the medics can review at their own outpatients and stop in the next review. Ensure that the diagnosis of delirium is documented both in the patient's hospital notes and in their primary health records, include in the discharge letter or summary. So in the discharge summary, the medics should put delirium in the problem list. And that's a learning point from me as well, like including the previous episodes of delirium in the problem list if there are, especially in the cases with delirium. Now, drugs to use to treat delirium. So I think I will start with olanzapine, and then I will go with others. So oral 2.5 to 5 milligrams OD, and then can become BD or go up to maximum of 20 milligrams per day. Sedation is the most commonly reported adverse effect, an increased risk of stroke in patients with dementia with all the antipsychotics. The second line, haloperidol, so 0.5 to 1 milligrams BD, very small doses of haloperidol. Every 4 hourly you can use if needed, because the peak effect you see, although the half-life is 72 hours, the peak effect you see within 4 to 6 hours. That's why you can use it up to QDS or up to TDS in such cases. in delirium. But in psychosis, you're not seeing the peak effect. So in psychosis, you can go with the BD doses or sometimes OD doses. But here you can go with the TDS doses or even BD doses are enough even here. So IM again 0.5. Don't give like 5 milligrams of haloperidol. Try to give as low as possible. Only half a milligrams should be enough. 1 milligrams, especially in the elderly patient with learning disability. They need very low doses. EPSEs can occur especially at the doses above 3 milligrams. So don't give higher doses. Rather give some promethazine in addition if you have to, but try to keep the haloperidol dose especially very low. Prolonged QTC interval both with olanzapine and haloperidol, especially with haloperidol. So that's one of the reasons we avoid it. Increased risk of stroke in patients with dementia, and all these antipsychotics, whether it's olanzapine, risperidone, all the antipsychotics increase the risk of stroke in patients with dementia. So if the patient is dementia and having superimposed delirium, try to avoid antipsychotics at all, and given it for a very short duration, 2 or 3, or even give it as a PRN there, because the risk of stroke in patients with dementia is quite high. So there you can better give it PRN. Considered first line agent haloperidol, but nowadays the trend is changing, and olanzapine may become the first line agent in coming years. Baseline ECG is recommended for all patients, and especially for the elderly or those with a family or personal history of cardiac disease. So when we come to the causes of delirium in the next slides, ECG is there, but ECG to rule out the cause of delirium. But here we are giving them antipsychotics. So it's also to monitor the response of antipsychotics. So ECG should be a first line investigation in all patients with delirium, irrespective of the cause. And regular monitoring of the ECG potassium level, so important, because if they're having hypokalemia, they can go into torsades pointes, and with that they can their prolonged QT interval from the drugs and from torsades de pointes from hypokalemia, and both can combine to give ventricular fibrillation, which is not a desired thing. Avoid in Lewy body dementia and Parkinson's disease, and all kinds of dementia. If you can avoid antipsychotics, that's the ideal. And like lying is a very bad thing, but sometimes in Lewy body dementia or Parkinson's disease dementia, advanced dementia cases, you might have to do therapeutic lying, telling a lie therapeutically, although that should be the last resort. For example, uh, if the dementia patient with delirium is saying, "Oh, the line is coming," you can, and you know that you can't give them antipsychotics. Just reassure them, "Oh, okay, okay, it will go away. Don't worry, it will go away." Something like that. Or they say that they want their mother, their late mother, to stay with them, and she will be with them in the dinner. You can say, yes, we will invite her. Don't worry, don't worry. So you can reassure them, and to some extent, some minimal amount of lying is allowed, because if you give antipsychotics, that will do more harm. Although the concept of therapeutic lying is controversial, just like the COVID, like the covert administration of drugs, that is also controversial. Sometimes you have to do these things. Avoid intravenous use. Now, intravenous, let the ICU staff use haloperidol if they want to. You cannot recommend to them. They know if it is written in their books that they can give in ICU haloperidol infusion at such and such rate, let them do that. But you will neither advocate nor condemn that. So it's their own choice if they want to use in severe agitated patients who are pulling out their NG tube or their tracheostomy or their oxygen tube all the time. If they want to use, it's up to them. You will just say your recommendation will be either oral or maximum IM if oral is not possible. And IV will be their choice. And they can use it only in ICU with the close continuous ECG monitoring. So it's their department. Okay, second generation olanzapine and then aripiprazole. Aripiprazole I would tend to avoid because akathisia is a side effect and that can worsen the delirium. So I would keep that in the bottom of my list. Amisulpride you can use, but again, like haloperidol, it has no antihistaminic activity. So and not even any anticholinergic activity. So it's like haloperidol. So so I can consider it, but not routinely. Risperidone, yes, risperidone will be the next common after. I think after olanzapine, I would tend to use quetiapine, then risperidone, then haloperidol, then amisulpride, and uh, then aripiprazole. And I would tend to avoid ziprasidone because ziprasidone prolongs the QT interval. It's so common, so I won't use it at all. So aripiprazole will be my last choice. If there is already so much QTC prolongation in a patient that their QTC level is already 550 without any antipsychotic, then you have no choice than to use aripiprazole for their hyperactive delirium. So in those cases, I can use aripiprazole or sometimes amisulpride. Benzodiazepines, so usually for emergencies, they can cause respiratory depression, oversedation, they can cause or increase the risk of aspiration pneumonia. Diazepam, uh, again, if there is a alcohol withdrawal, yes, you can use, otherwise, why to use? Cholinesterase inhibitors, yes, in patients with Lewy body dementia, you can use cholinesterase inhibitors to control the agitation. And you might have to take some resort to the therapeutic lyes plus cholinesterase inhibitors. And you can avoid benzos, you can avoid the antipsychotics, and you can avoid the anti-Parkinsonian drugs as well if you can. So, and then cholinesterase inhibitors will be the drug of choice there. Melatonin, trazodone, sodium valproate, they are also recommended as third line agents. They're just mentioned in the Maudsley prescribing guidelines. So pharmacological prophylaxis. Most studies use low dose haloperidol in patients deemed at high risk of developing delirium. I would rather go for low dose olanzapine if possible. And this is in the high risk patients. So, but you do not use that in very routine. There should be very rare occasion where you have to use the prophylactic olanzapine or haloperidol. If you know that there are previous episodes of confusion, each time they go to delirium inevitably, and it is very hyperactive delirium, then you can use prophylactic. Otherwise, routinely we don't use. And in elderly patients, low dose antipsychotics can have serious adverse effects. So try to avoid the prophylactic antipsychotics. and delirium workup. So a full history, confusion assessment method, CAM, uh, which I sent to you earlier or showed to you earlier. Define symptoms, acute onset. So do all the symptom profile. Take a collateral history, especially the past history of delirium, medication history, epilepsy history is so important because what happens is all your blood tests are normal and the medics are saying the patient is not delirious, patient is psychotic, and the patient is clearly saying that he is in a hotel, he is not in the hospital, and it is and he is in 2016 and it is the month of March, and uh, and then he's taking like a bit of like drowsy spells as well, may or may not, but you know that. And once you go on the history patient's notes, he has epilepsy and he's not taking epilepsy medications for years. And I had a patient 1 month ago like that. So that can happen. And what we did was that I got him admitted medically. They discharged him after 1 day, and his delirium got sorted after 2 or 3 days of discharge. So I think I feel that that may have been a premature discharge, but that's anyway. So epilepsy history, drug and alcohol history is very important. Then the examination. So the medical team should uh, like examine them, but sometimes if you want, you can have like in the years ago in 2002 when I was a senior house officer in services hospital, they called me for a patient who was confused and he was just having kind of verbigeration and not making any sense to his speech and just repeating the syllables. So when I saw and I was fresh, I I finished my medical internship quite freshly. So and when I went, I just saw at his neck. It seemed a bit stiff to me, and his eyes were kind of rolled up. So I said, why not checking the neck stiffness? And I checked for neck stiffness, and then and the other which starts from B. I've forgotten all those, but I examined for him for meningitis, and then told the team it is most likely meningitis. It's not ours, it's yours, and they took him and they treated his meningitis after that. So physical examination, it's a good habit that if you do physical examination yourself, you're not forbidden. Even if you are at a consultant level, don't feel shame to physically examine the patient. Although most of us do feel after coming to psychiatry and especially after becoming a consultant, why to, it's not our job. Yes, it's not our job, but we are at the end of the day, we have MBBS and we can do if we want at any time. So don't shy away from physical examination. Uh, Sometimes a patient can be constipated, constipation in itself in learning disabled patients, or sometimes the urinary tract infection can cause secondary to constipation, and they both can cause delirium. So ask them about the history of constipation, very common things. They're not the rare things, and they're one of the common causes. And if you come to those, you can just hit the nail. AMTS, abbreviated uh, mental state or mini mental state examination. Full workup. So I would go for ECG, in the very beginning rather than doing it at in the end. So FBC, electrolytes, glucose, LFTs, RFTs, thyroid, urine analysis, so urinalysis or urine culture and sensitivity to diagnose urinary tract infection, urine drug screen or blood drug screen Do you do urine drug screen? Is it available in Pakistan or not? And is it very expensive? Can anybody answer?
Well, it is available
Yes,
in
sir. It
Pakistan.
Yeah, and how much it costs?
Sir,
The urine
I
for
guess less than
12
4,000 rupees.
in
4,000 to
Lahore.
5,000 rupees.
Yeah, 4,000 to
In
12,000
Lahore.
rupees. Yeah.
4 to
Okay,
5,000, sir.
in Lahore, it costs 1,200 rupees for urine analysis from a local lab. But if you get the blood screening for drugs, then that is 5,000 from Chuktai lab.
Oh, okay, okay. Yeah, so usually blood drug screen we don't go for. It's in the books, but we never did that. So urine drug screen should be enough, and if yes, you can. If not affording, just take a collateral history and establish that they and presume, unless your hospital is willing to pay for the blood tests, do it. So, thiamine and vitamin B12 levels, vitamin D3 levels, I would also check nowadays, especially, and virologies, C-reactive protein. I think ESR is becoming more obsolete now. So, rather than ESR, I would go for CRP. Alcohol drug screen, HIV test, and virology, COVID testing. I would go for COVID testing before getting them medically clear. So I would ask them to send a COVID test, even if the patient is not delirious. I would just say to the A&E doctors, have you sent a COVID test? If not, send it, and then you take them to their ward and await for the COVID test result back. Test for other infections and HIV and serum marker for delirium. That's a new thing which came to my knowledge, and I've never done that. Calcium binding protein S100B. That could be a serum marker of delirium that can go with the higher levels are seen in patients with delirium when compared to patients without delirium. So that could be one thing you can use, but we never did that in practice. And I'll have to inquire our labs whether any lab does that or even not. Because sometimes these studies they come from America, and there are some things which are done. America is the most advanced, so they do some things the very first time it comes in America, then to the UK, and then it goes to Ireland, and then rest of the world. That's how the research travels. Uh, Now the neuroimaging, so CT scan of the head. Ask your medics if you are suspecting something, have they performed a CT scan of the head or not? MRI of the head, EEG, and then other things. In some cases, lumbar puncture, like in the case I mentioned, it was a meningitis, so I suggested do a lumbar puncture for this patient, and they did. Pulse oximetry and ECG should be the very first thing. Uh, Now, AEC scores of drugs. Are you aware of it at all?
No.
Okay. I was also not aware until I prepared this presentation. So you're not the only one. So this, if you see this slide, medicheck.com. So medicheck.com and check without K, medicheck.com, and you can you can open it later on, but this tells you what medication is having anticholinergic side effects to what degree. And I think, if I'm not wrong, they might have a uh, Android app as well. So if you are prescribing and if your patient is at high risk of getting delirium or even dementia, try to use less anticholinergic medications if you can. So I just picked some of them with 3 stars, three star or 3+ medications are the most at risk. So imipramine, chlorpromazine, and promethazine. Image. Oh yeah, you took a screenshot. Yeah, I will send all these slides, don't worry. Okay, and if you want my previous slides from catatonia or repo, just say to me. If you don't say to me, I might forget. So yeah, so remind me, I will send all the slides. And you can, I don't think there is a need of taking screenshots because I normally do send. Just remind me some other time. So olanzapine, clozapine, promethazine. So olanzapine is a 2+. So that's why it is good that anticholinergic side effects will prevent something, the extrapyramidal side effects, and it is not very high anticholinergic at the same time. So that's why it is ideal to use. And when you open the website or the app, this is what you get: AEC scores. So you add custom drug, you go on the top search bar. There may be different search bars, but you go to the top one because the system will acknowledge the drug only if you write in the top search bar, and then you do that. And I think let me open it for you, medicheck.com. I will open and then I will screen. I'll ask you if you are able to see the screen. So yeah, you can see the slides. Yeah. So I benefited from Leishman's, organic psychiatry, Maudsley prescribing for physical health, and Maudsley for psychiatry, and e-medicine from medscape.com. So thank you very much. But before we finish, I want to show you the MediCheck. So I go to call and share screen, switch between the screens, and MediCheck. Switch screen. Can you see the screen now?
Yes.
Okay. So medicheck.com, and it is available on Google Play as well. So review and withdrawal. So there are 3 categories. The scores at 3. There is a score of 3. Then consider it's made by the South London and Maudsley. So it is made by the Maudsley NHS Trust itself, and that's why they included that in the Maudsley prescribing guidelines. So it's and Maudsley is in a kind of hospital in London where the guidelines are published. So 3 score will be review and withdraw or switch, and 2 again score of 2, review and withdraw or switch. Number 1, caution required. 0 is safe to use, and if there is a question mark, you don't know. So let's start the medication. So let's say the patient is on atorvastatin. Yeah, atorvastatin is detected. So click to add. I added atorvastatin, and then add a custom drug. So let's do the haloperidol. Click to add. So far it is going 0. And can anybody name any drug you want to add? Most commonly metformin. Okay. Yeah. Click to add. Any other drug? So metformin has -1. -1 means that you don't know. So the overall score still remains 0. Now any drug with with the higher propensity. Name something with a medium or high propensity.
Could be Cameron.
Okay, procyclidine, very good. Okay, because it is in itself is so look 3, and when the score is 3, that means total AEC score is 3, and then interpret the scoring. So, and we are already kind of interpreted as that avoid if at all possible. And if we, let's say for risperidone, so click to add, so it will, risperidone is 0, amazing. And olanzapine, I think it should have 2. Yeah, olanzapine is 2. So that's where you can and check that you know it has actually Turkey sign, Turkey flag is there, and UK flag is there, but sometimes the UK websites you are not able to use anywhere else. So let me know in the WhatsApp groups that if it is available, if you can access this website in Pakistan,
Right.
or if you can even download this app from this website or not. So I think that's it for today. Any other questions?
No, sir. Thank you, sir.
Nobody else? No questions?
No, so we've asked in between, I guess.
Yeah. That was good, and you named it as a interactive session, so that was okay, and we really made it
Sir,
interactive. Yes,
sir,
sir.
yes, sir. There is one question I have seen in India that many time it requires titration of medication dose. Like fixed dose many time doesn't work. What kind of risk we should expect if there is a titration?
Titration up or titration down, you mean?
Up, sir, up titration.
Yeah,
Suppose
like
we are taking, for example, in India, what happened is haloperidol is very cheapest medicine. People may not afford many time olanzapine. So what we used to give is, for example, haloperidol we are using. So many time it
yes,
happens that the recommended dose usually doesn't control because usually they usually they call psychiatrists when the severe symptom is there. Mild, moderate, many
yes,
times
yes, yes.
they don't ask only. So what kind, how it can be done, or what kind of this thing, any adverse event we can expect in titration, or how we can proceed?
Yeah, I think, like they say that any dose above 3 milligrams or above will per day will cause extra pyramidal side effects, and then you will have to give anticholinergics. So try to keep it under 3 milligrams. If you have to increase 5 milligrams, maximum 7.5 milligrams. If not, then don't go above that. I would avoid, and then as a last resort, maybe combining some lorazepam or something, but go with slow titration, and that's what I would say. Trazodone can be sometimes used for aggression if it is cheaper. I don't know how much it costs in India, but or I mean, India is like we also used to and maybe still import raw material from India for medication. So like risperidone and olanzapine, there are very cheaper versions available in India and Pakistan, locally made, and even in India it should be even more cheaper because like India makes the raw product as well. So I think you may have alternative, and you can use the generic olanzapine and risperidone rather than going to haloperidol.
I
But
hope.
yeah, but you can use low dose haloperidol as well.
Thank you, sir. Thank you.
Okay, any other question? So we just stop it here, and thank you for joining everybody, and it will be, hopefully it will be available on YouTube by this evening. Okay.
Thank you.
Love this.
Thank you